Hello and welcome to this presentation for Health Service Research UK Conference 2020. My name is Nicola Hancock from the University of East Anglia, and I speak today on behalf of myself and my co-author Julie Houghton. I'm speaking about small steps to big changes, transforming practice with supported self-management training in neurorehabilitation services, the People First project. And I'm going to discuss the project in terms of the concept of supported self-management in neurorehabilitation, the stages of the work undertaken, the theory and practice of the embedded evaluation, and its findings, with plans and indicators for sustainability. So what is the People First project? Well, this was a major quality improvement initiative funded by Health Education England in the East, and the work consisted of the rollout of the Bridges Supported Self-Management staff training programme in stroke and other neurorehab services, with an embedded evaluation led by the University of East Anglia. This was the first independent evaluation of Bridges, and the scale here was pretty huge. We worked with 6 sustainability and transformation partnerships, 24 trusts, and in total 750 training places were on offer. Our overarching objective was to determine if the Bridges supported self-management model could be successfully embedded and sustained in neurorehabilitation practice. So what is supported self-management? Well, this is really about the person living with a condition being at the centre of managing life with the condition. It doesn't put the healthcare professionals and services at the centre, but very much the person. It's a move away from the paternalistic models of doing to service users. And supported self-management has been linked to positive outcomes for service users, but also for service efficiency and staff satisfaction. And the importance of implementing self-management programs is widely accepted, but questions do remain as to how. And the focus here on stroke and neuro rehabilitation services is important. Embedding and sustaining these kind of approaches in rehab practice really has the potential to encourage stroke survivors' independence and quality of life, and hence national clinical guidelines for stroke do recommend that staff are supported in developing their knowledge and skills in this area. And the Bridges programme does just that. It's an individualised approach based on self-efficacy principles. And we see in the diagram on the right here that professionals are trained to use strategies and principles of self-management, such as reflection, self-discovery, goal setting, and developing plans and solutions right alongside patients, promoting their feelings of success and self-mastery. Bridges have an established training programme, and this slide just shows the stages of the training and our evaluation. Activity begins with raising awareness and gathering information about the context in which the training will sit for a particular service. For this project, the UEA team also gathered information from some service user stakeholder groups, such as Headway, but this won't be reported here. Training then begins with a full day, Knowledge Zone 1, then a few weeks of implementation, a follow-up half-day workshop known as Knowledge Zone 2, and then after about 3 months, a masterclass with local champions where local sustainability plans are shared, discussed and refined. So on to our evaluation methods and the underpinning theory. We ran a theory-led analysis of the Bridges training programme, and our materials were developed collaboratively with the Bridges team. We used Kirkpatrick's 4 levels of evaluation for adult learning and also normalisation process theory. And reporting here today will focus on changes to practice and perceived benefits to services and service users according to Kirkpatrick's model. The model uses 4 stages: reaction, aspects of training that motivate change; learning, knowledge, confidence and skills; behaviour, how that learning is translated into behavioural change; and results or perceived benefits of a training programme. This was a multifaceted evaluation. We used a number of tools in order to triangulate as much information as possible. So we used questionnaires, both before and after the introductory training day, and after the initial 12-week implementation period. We also used semi-structured interviews with a subgroup of multi-professional participants post the initial implementation phase, where we looked at things like the nature of the changes made, the perceived benefits, barriers and enablers to supported self-management in practice. And also the evaluation team observed training, looking at the structure and content, the interactivity and the feedback responses gleaned on the day. So you can imagine we had a very substantial data set here. And on that note, this slide just demonstrates the amount of data generated from the 650 training places taken up across a wide range of health professionals. Unfortunately, we didn't have any medics engaged in the training, but huge numbers of questionnaires were returned, and we undertook 24 practitioner interviews and over 100 hours of training observations by the evaluation team. So what did the evaluation find? The evaluation recorded a very positive reaction to training by participants. It really resonated with practitioners' intrinsic motivations for working in healthcare, took them back to their values. Many of the practitioners talked about being taken back to why they came into healthcare in the first place, to care for and to help others, and to contribute to high quality care. But it also enabled valuable time and space away from clinical practice to reflect on that practice. They also really valued the interactive nature of the training, credibility of the trainers, and the use of the patient voice throughout the training was really valued. And so much learning went on. It wasn't a surprise that the practitioners involved in the training, being in stroke and neurorehabilitation, had an excellent baseline position of person-centred care. But we saw a definite shift to increase confidence in using the person's choice as a basis for care, using the person's priorities in goal setting, and really helping people to develop insights when perhaps their goals weren't met. And that was felt to be particularly important. But the practitioners also spoke about time needed to consolidate their learning and to grow further in terms of what they'd learned. And moving on now to consider some of the changes to practice that were reported by the practitioners. And there are a number of sort of key themes that emerged at this point of the evaluation. Lots of practitioners reported adapting their language and the structure of their interactions with patients and families. Both individuals and teams were moving towards a more open questioning approach, coming away from a model of instruction and offering solutions, and really thinking about altering their goal-setting approach, encouraging patient reflections and problem solving, and thinking about what's really important to the service user. We also had reports of practitioners revising their paperwork and processes to embed supported self-management and make it a much more visible part of what they were doing. And like all funded evaluations, our funding and the evaluation at some point has to draw to a close. So it's really important that we understand planned actions and what teams are thinking about doing to sustain their changes long term. And lots of these changes were underway. People were talking of changes to the ward environment, for example, information boards and posters. Supported self-management was being included in induction and training packs for staff and built into competency frameworks and KPIs. And also service user feedback was being used much more strongly to develop new resources, and the teams were auditing how that was being done. We also saw that there were aspects that teams were finding quite challenging. For example, current measures used to report on services they felt didn't really encompass this supported self-management approach, and many of them were working with their management teams in order to think about what measures might better capture this approach that they're now using. And we see in the quote on the right here the importance of small steps towards big changes. This member of an acute team says, "We have realised that relatively small changes to the way we work can have a big impact on both patient and staff satisfaction. Those small incremental changes were noted to be of great importance." So in conclusion, and thinking about what next, it's important to consider how this approach might be sustained in the future following the positive findings from the People First evaluation. And I think we saw here a huge value from practitioners placed on small incremental steps to change, they feel more manageable in busy services. And that change generated by practitioners and service users is the change that's most likely to be sustained, but that supportive and engaged leadership teams are absolutely crucial to processes moving forward. Also, it's very important to understand the organisational context and some of the organisational barriers that might be in place to implementing such programmes. There's an important focus on truly person-centred care, and that the use of a common purpose and language supports positive change. Cohesive action, working together, is what helps to implement change long term. And the ongoing reflection here is a vital tool. Just because our programme or evaluation is drawing to a close, the work here has really only just begun, and the reflective nature of the practitioners involved is going to be hugely valuable moving forwards. And to finish, I'd like to share with you a quote from a nurse who was involved in the training programme. She spoke of the training re-energising staff. She said, most of us came into the job to help people, but feel we're being asked to do something quite different. The Bridges training allowed us to re-establish the personal human contact that makes our jobs worthwhile. So if that's not an example of staff satisfaction after training, I don't know what is. So thank you very much for listening to the presentation on the People First work. I hope you've enjoyed it. If you've got any comments or questions, please do add them below the video and we will read and respond to them. And I would like to acknowledge Professor Fiona Jones and members of the Bridges team, the clinical leads and team members included in the evaluation, all the trust governance teams that were involved in supporting the evaluation, and Health Education East of England for funding the evaluation and for their ongoing support with its administration. I hope the rest of the conference goes well for you all, and it's been a pleasure to speak to you.